entire screen.
My voice is loud and clear, right?
Yes, it's good.
Okay. And the other thing is, जो PPT है, you will be changing the slides?
कि अगर कुछ इशू होता है, लाइक फॉर एग्जांपल शेयर करते टाइम पे मोस्टली डॉक्टर्स लोग को मतलब कि ऐसे हुआ है कि ऑल ऑफ द सडन दे जस्ट फॉरगेट व्हिच वन टू क्लिक और समथिंग लाइक दैट. तो ये किसी जूम की प्लेटफॉर्म की तरह नहीं, बट इट्स सेम सिमिलर, इट्स मोर इजी देन दैट.
No, that can happen. Technical glitches.
अगर कुछ इशू होता है आपके एंड से तो ही मैं शेयर करूंगी, एल्स यू कैन ओनली शेयर.
Okay, fine. That's fine.
Yeah.
ठीक है. So I'll share my screen, right?
Okay, fine. You can share your screen.
Yeah, it's visible.
Yes, it's visible, but अभी कैसा है ना कि पूरे स्लाइड्स दिख रहे हैं. If you start the slide show और फिर शेयर करते हो तो वो ये होता है, मतलब कि पूरे पीपीटी प्रेजेंट, मतलब पूरा वो विंडो ही दिख रहा है पीपीटी का.
So मतलब मुझे stop sharing, share में जाके I have to select entire screen.
Yes, entire screen एक बार शेयर करके देखिए.
Yeah, now it's fine, right?
हाँ, अभी एक बार प्ले कीजिए पीपीटी, स्लाइड शो स्टार्ट कीजिए.
हाँ जी. Okay.
हाँ, now it's fine.
Alright.
ऐसे एंटायर स्क्रीन ही कर लेना सो दैट.
ठीक है.
आप ये जो मतलब नीचे ना मैं जहाँ पे डिस्प्ले हो रही हूँ, लाइक आई डोंट थिंक सो, लाइक कैसे when you start speaking ना, else you can just cut that.
Okay. नहीं ठीक है, it's fine. मेरे ख्याल से तो बीच में कुछ आएगा नहीं, स्लाइड सभी नीचे नीचे ही हैं.
Okay, fine. ठीक है.
हाँ ठीक है, हो जाएगा. Not an issue. A minute. Hello. Hello, yes. हाँ जी. हाँ जी मैम, इवनिंग से गल करते हैं, मैं मीटिंग से.
तो मतलब कि आपको है ना, जैसे आपका पार्ट एंड होता है या क्वेश्चन आंसर्स में कुछ क्वेश्चंस अगर पूछते हैं कोई, तो लाइक अगर वो पार्ट होने के बाद देन हमारे एक, जैसे मैंने कल आपको बोला था कि हमारे एक मेंबर ज्वाइन करेंगे एंड देन शी विल स्टार्ट, like she'll take over and then the webinar will end somewhere. Yeah.
I think यहाँ पे विंडो ऊपर ठीक है, राइट कॉर्नर में.
Okay. Okay.
So, कितने पार्टिसिपेंट्स एक्सपेक्टेड हैं?
डिपेंडेंट ऑन लाइक कि मैक्स टू मैक्स 60 होते हैं. 60 मतलब अभी तक तो 10 मतलब 100 के ऊपर ही हुए, मतलब अटेंडीज. रजिस्ट्रेशन कैसे होता है कि रजिस्ट्रेशन 200-300 हो जाते हैं, बट कभी कभी क्या होता है कि 100 ही 100 लोग ही ज्वाइन करते हैं या 60 लोग ही.
हमारी कितनी रजिस्ट्रेशन हुई हैं?
हमारे इसमें आई गेस 75 रजिस्ट्रेशन हुए.
आई थिंक 50 तक होने चाहिए स्ट्रेंथ.
यस. ओके, मतलब बाहर के भी लोग ज्यादा रहते हैं ना, तो उनका क्या होता है कि ड्यू टू सम टाइम जोन इशू माइट बी दे आर नॉट एबल टू ज्वाइन. ऐसे मुझे वी आर गॉट फीडबैक फ्रॉम दोस पीपल. यस,
इट्स गोइंग टू बी रिकॉर्डेड.
यस, इट्स रिकॉर्डिंग.
ओके, एंड देन दिस विल बी अपलोडेड ऑन योर साइट फॉर
नो
फ्यूचर.
कि इट्स नहीं, मतलब ऐसे हम अपलोड नहीं करते.
ओके,
मतलब अभी तक तो नहीं किया है.
अच्छा ठीक है.
इफ यू वांट टू अपलोड, लाइक अगर आपका कोई यूट्यूब चैनल हो या
नहीं, आई एम जस्ट आस्किंग कि अगर जो जैसे अटेंडेंस हैं जो रजिस्टर कर लिया बट आ नहीं पाए, बाई चांस अटेंड नहीं कर पाए, तो वो आगे देख सकते हैं, क्योंकि ये बेसिकली इट विल हेल्प एमडीएस स्टूडेंट्स मोर देन द बीडीएस वंस.
राइट.
जो मैक्सिलोफेशियल में कर रहे हैं ऑलरेडी, उनके लिए काफी हेल्प करेगा. तो दिस इज द राइट्स।
हाँ, वैसे हम उनको रिकॉर्डिंग सेशन लिंक शेयर कर देते हैं तो दैट दे कैन एक्सेस फॉर मोर देन लाइक 7 days के मतलब बीच में आफ्टर 7 days इट गेट एक्सपायर। मतलब हम 7 days ही वो एक्टिव रखते हैं।
ठीक है।
या तो वैसे करते हैं जो भी अटेंडीज मतलब जो अटेंड नहीं कर पाते उनके साथ में टोटली डॉक्टर स्पीकर के ऊपर रहता है। इफ ही वांट्स टू शेयर दोज स्लाइड देन तभी हम मतलब रिकॉर्डिंग शेयर करते हैं। वी डोंट शेयर विद एनीवन।
वीडियो ठीक है, कोई लैग तो नहीं आ रहा ना इसमें?
नो नो,
स्लाइड
इट्स परफेक्टली फाइन, परफेक्टली फाइन, नॉट एन इशू।
सो अभी स्टिल है 15 मिनट्स, अभी ज्वाइनिंग शुरू हो जाने चाहिए ना?
या तो टिल देन आई विल जस्ट शेयर माय स्लाइड। मतलब मेरी सो आपको मतलब कि जैसे मेरा पार्ट एंड होता है आई विल मेक यू द प्रेजेंटर।
ठीक है, फाइन।
ओके, तो अभी आपको अलग स्क्रीन दिखेगी लाइक इट्स 15 मिनट्स मोर आई गेस। या मैंने बहुत अर्ली स्टार्ट कर लिया है।
नहीं, मुझे बेसिकली सिग्नल स्ट्रेंथ का डाउट था, तो इसलिए
ओके
मतलब कुछ मूव करना हो इधर उधर लोकेशन में तो देन वी कैन डू दैट।
ओके फाइन देन विल देखते हैं हम जैसे अटेंडी स्टार मतलब ज्वाइन करते हैं।
Sure.
ओके फाइन।
I'll stay there. I'll just stop my video and
ओके
just.
ओके फाइन फाइन, इवन आई विल स्टॉप दैट एंड आई एम गोइंग टू शेयर माय स्क्रीन। ओके
Okay, fine.
फाइन, थैंक यू। available to our intrinsically connected, especially when it comes to oral health and the cancer prevention. So Dr. Rajan Dev Insight will be shed the light on this intersection and provide the valuable insight. So in addition to our estimated speaker, I am thrilled to announce you to our collaboration with ABS Dental Doc, Patiala mentor, Dr. It on the spot effortlessly, saving your time. Denti keeps you informed so that you can stay finger fingertip, whether you are
Hello. Hello. Am I audible?
doctor, you are audible. Yes, you are audible.
Share the screen.
You can share your
Yeah. So my slides are visible, right?
yes, it's visible.
All right. So thank you for the opportunity, and I thank Denti and AB Dental Docs, and also I would like to request everyone to follow the group for the regular updates. And so today we are going to discuss on the maxillary tumors. So as we all know, maxilla tumors are not very common, but they are very complex and very difficult to treat and operate on. So we'll discuss the basics of maxillary tumors
surgery and the reconstruction and rehabilitation part. So, shall I start my presentation, right?
Yes, doctor, you can continue.
All right. So maxilla is the second largest bone of the face, as we all know, and there are bilateral maxillas, and they start from the upper jaw, and they have multiple relations. So to perform the surgery, we have to be well aware about the anatomy of the maxilla and all the relations of the maxilla. So it has three cavities. First is the roof of the mouth, and then floor and lateral wall of the nose, and floor of the orbit. So the bony anatomy has to be particularly taken care of. So in this, the the main important subside of the maxilla is the pterygomaxillary fissure, because this is the only part which is going to decide whether the tumor is resectable or unresectable. So once this pterygomaxillary fissure is uh, involved by the disease, so usually these tumors have very poor prognosis, and usually they are not resectable with negative margins. So body of the maxilla, it is the largest cavity. It's a pyramidal shaped, and midly the base is directed at the nasal surface. Apex is laterally directed towards the zygomatic process, and roof of orbit roof is formed by the floor of the orbit, and floor is formed by alveolar process of the maxilla. So likewise, it has four surfaces: anterior, which is also known as the facial; posterior, which is the infratemporal surface; superior, which is orbital surface; and medial, that is the nasal surface. So in this, again, the posterior or the infratemporal surface is the most important part for the deciding the resectability of the tumor. So there are four processes of maxilla: zygomatic, frontal, alveolar, palatine process. And similarly the articulations of the maxilla. So it articulates with three bones: nasal, frontal, and lacrimal process. So medially, five bones are there: ethmoid, inferior nasal concha, vomer bone, palatine, and opposite maxilla. Laterally with the zygomatic bone. So these are just the diagrammatic representation of the maxilla bone. So what we have studied, all the surfaces, we can just see over here. And then coming on to the superior part, orbital surface. So this is of particular importance while performing the total maxillectomy as well as the extended or radical maxillectomy. So the posterior border of the orbit, which is smooth and forms the anterior margin of inferior orbital fissure, and in middle, infraorbital groove is there. So medial border, it is formed by anteriorly lacrimal notch converted into nasolacrimal duct, and behind the notch there is articulation with the lacrimal labyrinth of ethmoid and orbital process of palatine bone. So these relations are very important while performing the orbital exentration. So in this also we have to particularly take care about the orbital plate and the infraorbital groove. So once the optic nerve or infraorbital groove is involved, it becomes really difficult to resect these tumors. Likewise, the medial or the nasal surface, so it's the lateral part of the nose, posterior superiorly by the maxillary hiatus, and above the hiatus there are the air sinuses, and below the hiatus there is anterior part of inferior meatus, and behind the hiatus it articulates with the perpendicular plate of palatine bone, and also encloses the greater and lesser palatine canals. So this is just for your diagrammatic representation, to just have a look about how the real anatomy looks like. So we will just talk a little bit about the processes of maxilla. So the first one is the frontal process, then zygomatic process, alveolar process, palatine process. So these processes are particularly important while doing the osteotomy cuts in maxillectomy surgery. So we'll see in further slides the procedure of maxillectomy, and in that procedure you will find out why these processes are important. So there is a particular sequence of doing osteotomy while performing a maxillectomy. So these processes are of particular importance. So talking about the frontal process, It projects upwards and backwards to articulate above with the nasal margin of the frontal bone, and in front with the nasal bone, behind with the lacrimal bone. And lateral surface, it is divided by anterior lacrimal crest into anterior smooth and posterior grooved surface. Anterior lacrimal crest, it gives attachment to the lacrimal fascia and the medial palpebral ligament. So medial surface, as we have discussed before also, it forms the lateral wall of the nose. From above downwards, if we go, the uppermost roughened area is for the articulation with the ethmoid bone, and ethmoidal crest it's the horizontal ridge which articulates with the middle nasal concha, and below the ethmoidal, then below the ethmoidal crest, it's the atrium of middle meatus, conchal crest, and inferior meatus. So zygomatic process, it is the pyramidal lateral projection. So what this is the process which can be felt very easily, the prominence on your cheek just below the orbit. So this is the zygomatic process, and it's very prone to the fractures as well. And this step is the most important part while performing the maxillectomy. So superiorly it is rough to and articulate with the zygomatic bone. Then comes the alveolar process. So it forms the half of the alveolar arch. Basically, this alveolar process divides the maxilla into two parts, and this basically forms the hard palate in the mouth, and it bears the socket for the maxillary teeth, and the muscle which takes origin from these processes is the buccinator muscle. And the palatine process, it is a thick horizontal plate projecting medially, forms largest part of the roof and floor. Inferior surface, it is concave and forms the anterior 3/4 of the bony hard palate. So this hard palate or the palatine process, it has various foramens and pits for various purposes. So the most important is posterolaterally greater and later palatine foramen, or the greater palatine nerves, and then for superior surface, which is also concave, and from side to side forms the floor of nasal cavity. So medial border, so it is thicker anteriorly, and there is a groove between nasal crest of two maxilla, receives lower border of vomer, anterior part of the ridge in incisal crest and anterior nasal spine incisive canal. Then posterior border, it articulates with the horizontal plate of palatine bones, and lateral border, it is a constant continuous with the alveolar process. So what we have studied till now, we can just see in this picture. So A part, the largest foramen, this is the incisive foramen, and then mid-palatal suture, which basically articulation of both the palatine process, and so on. So just little bit about the innervation and the blood supply. So posterior superior alveolar nerves and arteries, infraorbital nerves and arteries, anterior superior alveolar nerves and arteries, then superior artery of inferior concha, which enters through the ostium of sinus, veins and lymphatic vessels, which drain via ostium into the nasal cavity to the submandibular nodes. So maxilla, it has enriched nerve supply. It's really painful due to the rich nerve supply, and these nerves have to be sacrificed while doing the maxillectomy. Now the second vascular part. So mainly the bleeding which occurs during maxillectomy is through the maxillary artery. It has numerous branches. So we have to ligate this branch at the origin. And sometimes, in some cases, when the bleeding is not controlled, then we may have to ligate the external carotid artery as well. So let's talk about the maxillary tumors. So these are one of the most challenging problems in the head and neck cancers. These tumors are rare. They are difficult to operate with negative margins due to their anatomy and rich blood supply. And the second most important part in these tumors are due to relation with the orbit. So initially, these tumors, they start with generalized symptoms, usually the symptoms of sneezing and regular sinusitis symptoms. These tumors, they have high morbidity due to complex surgeries
and poor prognosis because they are detected in a later course of time in comparison to other oral cavity tumors. So these they comprise around 0.2 to 0.8% of all malignancies. Incidence, it varies from 0.1 to 1 per 1 lakh population per year, and 3% of all tumors of head and neck. They usually present in the 5th and 6th decade, and they have slight male predominance. So depending on the site, maxillary sinus is the most common site of origin in maxillary tumors. Second being the nasal cavity, third ethmoid, and very rarely in frontal and sphenoid sinuses. So most common lesions, depending upon the histopathology, most common is the squamous cell carcinoma. So 70 to 80% of the maxillary tumors are usually squamous cell carcinomas, and other rare varieties being adenocarcinoma. Usually these adenocarcinomas, they are related to the occupational hazards such as wood industry workers, nickel industry workers. They are more prone to the adenocarcinoma variety. Then sarcomas. In young age, you may have sarcomas, and very rarely you can have salivary gland tumors invading into maxillary sinuses, which are mucoepidermoid high-grade tumors. So etiology, usually it is a occupational hazard. So apart from the smoking and tobacco, the routine cause for the cancers of head and neck, maxillary tumors, they have specific exposure and etiological agent, and those are woodworkers, as we discussed, hardwood workers. So adenocarcinoma variety is relatively common in hardwood workers. Then leather industry, chrome pigment industry, nickel industry, alcohol industry, textile industry. So basically it is linked with the dyes and the wood dust. So apart from the WHO classification, histological classification, so these are basically divided upon the cells of origin. So epithelial origin are epidermoid, which is most common is squamous cell carcinoma, and in non-epidermoid variety, adenoid cystic, adeno, mucoepidermoid, acinic cell. These all are minor salivary gland cell tumors which usually invade. They arise from hard palate and they invade into the maxillary sinus. By and large, the treatment for all these varieties, they remain same, and the primary treatment being the surgical excision. So just little bit about the squamous cell carcinoma, as it is the most common form of histological type of maxillary tumors and overall head and neck tumors. So most common site is maxillary sinuses, then ethmoid, then sphenoid, and risk factors for particularly for squamous cell carcinomas are inverted papilloma, thoracoast, and nickel industries. So present at advanced stage, 80% of the patient, they present in stage 3 or stage 4. When the bone is involved, then and the swelling is visible on the cheek, only then these patients, they turn up into the OPD. So tumors from the nasal cavity are keratinizing usually, and from the PNS, they are non-keratinizing type. And these are poorly differentiated histology, and undifferentiated histology is also present, and usually these are seen in cases of sinonasal and melanomas. On grossly, these tumors, they appear mostly they are exophytic or fungating type, and they are very much friable. When you try to take the biopsy from the hard palate, they are usually necrotic, and the chunk comes very easily. So this is particularly a landmark which is very important in determining the prognosis of these patients. So this was classified by Ongren's. It's called Ongren's line. So this is an imaginary line which connects medial canthi to the angle of mandible. So usually, if we see in a broader sense, this divides the maxilla into two parts. So infrastructure and suprastructure. So now these two parts, they have relevance, one in surgery and second in prognosis. So the tumors arising from the suprastructure above this line, they have relatively poor prognosis than the infrastructure tumors. And For infrastructure tumors, the surgery is also less complex than suprastructure tumors. Usually, for the infrastructure tumors, we are done with the infrastructure maxillectomies, and with the clear margins, and reconstruction is also very easy. But for suprastructure tumors, we have to go for total maxillectomy and some cases orbital excision. So just like organs, there is another classification which is Lederman's classification, and basically it has 4 imaginary lines, and it divides again the maxilla into 3 parts. So in this we have another mesostructure part apart from the infrastructure and suprastructure. Again, the infrastructure part, the treatment, the prognosis is very good, but as we move above the prognosis, it starts decreasing. So, what are the common clinical presentation or findings in these patients? So, as we see, whenever there is some mass or tumor which is arising from the maxillary sinus, from the mucosa of the maxilla, so it tends to block the maxillary sinus, and simultaneously it can block the nasal pathway. So usually the patient complains of obstructive nasal symptoms like nasal blockage, sometimes bleeding from the nose, hyposmia. There can be a mass, there can be ulceration if the disease has progressed to stage 3, stage 4. There can be erosion of the anterior wall of the maxilla, and then we can see a visible ulcer or disease on the cheek. And likewise, it can invade into hard palate and just form a lesion on the mucosal surface of the hard palate. Then it can lead to middle ear infusions, glabellar mass, paresthesias due to involvement of nerves. Infraorbital nerve can be involved, then it can cause the paresthesia of particularly infraorbital nerve, then loosening of teeth. So sometimes there is just one symptom of loosening of tooth. So patient is comes to a dental clinic and gets evaluated for loosening of tooth, and there is no other sign and symptom which patient is complaining of. And just when you try to separate the tooth, you see friable growth present at the root of the tooth. So it is really common in maxillary tumors and otherwise also in oral cavity tumors, where the only complaint of patient is loosening of tooth. There is no ulcer, no growth, nothing, no bleeding. Just only complaint is loosening of tooth, and you try to remove the tooth, there is a ulcerated growth, friable growth at the root of the tooth. And very advanced cases, it may lead to oroentral fistulas. Orbital involvement can lead to proptosis, diplopia. So, what is infrastructure basically? So, infrastructure is the basically starting part of the floor of the antrum, then oral cavity, then middle wall of the nasal cavity, and through its anterior wall of the soft tissues of the cheek, and lateral wall into the masticator space. So suprastructure. So tumors in suprastructure, they can extend up to the posterior wall of the antrum into pterygomaxillary space. So why the suprastructure tumors are have less prognosis? Because pterygomaxillary space or fissure is very near to the suprastructure part, and as we discussed, once this space is obliterated, resection becomes very difficult, and it's very difficult to have negative margins while performing surgery. So then suprastructure, from suprastructure to infratemporal fossa. So same with pterygomaxillary fissure, ITF involvement is usually unresectable. You cannot attain the negative margins unless you are doing very complex surgeries, which may involve the base of skull surgeries as well. So through the roof of antrum into the orbit via ethmoidal air cells to the anterior cranial fossa, and through the orbit into the perineural spread can happen, and it may lead to involvement of optic nerve. So lymphatic spread, usually lymphatic spread is very less in maxillary tumors compared to the oral cavity tumors like GBS sulcus or buccal mucosa tumors. They to lymphatics in 25 to 30% of the cases only. Tumor, usually the lymphatic spread, it increases when the stage has advanced. There is involvement of the cheek skin, there is involvement of the mucosa of the hard palate. So in those cases, we can expect higher chances of lymph nodal involvement. But still, the contralateral metastasis of the opposite neck, it's very, very rare. Distant mets, it can occur. So more common with the adenocarcinoma variety as it is more aggressive, and common sites being bone, brain, liver, lung, and skin. So coming on to the staging of the maxillary cancer. So T1 is limiting to the maxillary sinus mucosa with no erosion or destruction of the bone. And stage 2, causing bone erosion or destruction, including the extension into the hard palate,
middle nasal meatus, except to the extension of posterior wall of maxillary sinus and pterygoid plates. So now T3 in any of the below invasion, like bone of the posterior wall of maxillary sinus, subcutaneous tissue, floor or middle wall of the orbit, pterygoid fossa, ethmoid sinuses. Then the third, then the T4 stage, which is moderately advanced or very, very advanced stage, T4A, involvement of orbital content, skin of cheek, pterygoid plates, ITF, cribriform plate, sphenoid or frontal sinuses. T4B, usually T4B are unresectable tumors. So invasion into orbital apex, which is rendered unresectable tumor, dura mater of the brain, middle cranial fossa, cranial nerves, maxillary division of the trigeminal nerve, nasopharynx or clivus. So these are unresectable tumors. Up to T1A, some T1A tumors, we can still go for surgery provided we have that kind of setup. Prognosis is still better if we are able to achieve the negative margins, because chemotherapy, radiotherapy is not the primary treatment in head and neck tumors. The surgical resection with negative margin is the primary treatment in all head and neck tumors. So likewise, the nodal staging, so N1 is less than 3 centimeters, single node, ipsilateral side. N2, N2A, single ipsilateral node, more than 3 centimeters, but less than 6 centimeters with no extranodal extension. N2B, multiple nodes, same site, none more than 6 centimeters. And N2C, either bilateral or contralateral nodes or any node more than 6 centimeters. So particularly N3. So the prognosis depends upon the nodal stage as well. In this particularly N3B, N3B cases are very, very difficult to treat. They have huge rate of reoccurrences due to presence of extranuclear extension of the nodes. So N3B are very, very disturbing patients. So stage 1 T1N0, stage 2 T2N0, stage 3 up to T3N0 or even N1. Stage 4A is T4N0, T4A resectable tumors, and 4B NET with N3 means extranodal extension is present. Then T4C, which is metastatic lesions. So up to stage 4A and even in 4B, we can treat the patients. So for clinical evaluation, so first thing first is the examination history and complete oral cavity examination, and then endoscopy of the nasal cavity to look for the extension of the tumor, endoscopy of the pharynx, larynx for the complete head and neck examination for any satellite lesions, any synchronous lesions present in the oral cavity, the aerodigestive tract, and then comes the imaging. So for imaging, imaging is preferred before biopsy, so you know the complete extent of the disease, and then we go for the biopsy. For imaging, CT scan is good enough for the surgical planning, but only in cases of early maxillary tumors, which are very difficult to distinguish between the maxillary sinusitis or early maxillary tumors, we go for MRI scans. For proper bony assessment, CT scan is the best modality. For nodes, CT scan is the best modality. And in stage 3 and beyond patients, we usually go for PET scan or at least the CT scan of the chest to look for the metastasis. So CT scan, it gives good bony detail, proper extension of the tumor, and we can plan our surgery for the margins and also the plan of reconstruction. So as I told you, there are some limitations with the CT scan, particularly when there are inspissated secretions inside the cavity of the maxilla. Then it is very difficult to differentiate between sinusitis or maxillary cancer. So this is the general overview of the CT section axial cut, and this single axial cut is complete to plan your, to have a look around about the anatomy of the maxilla. See, so you can see a maxillary sinus, and there is a gray shadow in the left maxillary sinus. So basically, this can be secretions or this can be a tumor. So we don't really know. So in these, particularly these type of patients where there is no bony breach, there is just the collection of the mucus in the maxillary sinus, MRI is very helpful. And suppose there is some distortion of the bone anatomy, there is breach of cortex of the maxillary bones, then we are almost sure that this is maxillary tumor. So for sinuses, coronal section of CT scan is very important to look for the medial wall, to look for the orbital floor, and to plan our surgery and reconstruction. So this is the reconstruction CT. So what we see, the medial wall of the maxillary sinus is totally breached and the tumor has eroded the medial wall and extended into the nasal cavity. So as we discussed, MRI, so MRI is excellent for the soft tissue delineation and to differentiate between the maxillary sinusitis and early maxillary cancers. Plus, the main advantage of MRI comes when there is extension of infratemporal fossa. So MRI is preferred if you have any suspicion of infratemporal fossa involvement, because infratemporal fossa is bounded by bony margins on the medial side, but the contents of ITF are more of soft tissue. There are vessels, there are nerves. So MRI is better modality to comment on ITF involvement. So these are just the points which we have already discussed. PET scan. So PET scan is not mandatory in head and neck carcinomas. So PET scan is preferable if the stage is 3 and beyond. But we can also substitute PET scan with the CCT chest, because the most common metastases, they occur in the chest only. So treatment option, as we discussed, the primary or the mainstay of treatment is surgery, and followed by adjuvant treatment. In adjuvant treatment, post-surgery, depending upon the histopathological parameters, stage of the patient, ENE positivity or not, PNI is present or not, LVI is present or not, we take the decision for the adjuvant radiation therapy or combined adjuvant CT chemo plus radiotherapy. And in unresectable cases, with ITF involvement, grossly involved ITF, we usually prefer definitive CTRT for those patients. High dose CTRT, no surgery is recommended in the involvement of high ITF. And similarly, there is some role of giving neoadjuvant chemotherapy in advanced tumor which are borderline resectable or potentially resectable. So in these patients, we usually try to give neoadjuvant chemotherapy only 2 to 3 cycles of carboplatin and paclitaxel, and then reassess whether the disease has decreased or not. Again, the extent of surgery will remain as per the pre-chemo picture, but the surgery becomes really easy after decreasing the bulk of the disease. So all these tumors, or rather any kind of tumor, these are dealt in a multidisciplinary board. So there is a surgical oncologist or a head and neck surgeon, along with that a plastic surgeon for the reconstruction, then ophthalmologist, then speech therapist for swallowing and speech therapy, then prosthodontics, very important. We will see in further slides about the role of obturator, then dentistry for pre-evaluation as well as post-rehabilitation
Even we can do dental implants after reconstruction in maxillary tumors. Then medical radiation oncology for the adjuvant therapies.
So let's come to the management of maxillary tumors. So maxillectomy.
So maxillectomies, basically there are three types of maxillectomies. One is total maxillectomy with orbital excineration, which is also called as extended maxillectomy or radical maxillectomy. Then total maxillectomy, which involves the floor of orbit, and subtotal maxillectomy, which is infrastructure maxillectomy, then partial maxillectomies, then suprastructure maxillectomy, and medial maxillectomy. So of all, most common and routinely performed maxillectomies are infrastructure maxillectomies. Then extended maxillectomy, apart from orbital excineration, if we are removing any of the above, malar complex, phenol sinuses, contralateral maxilla, skin, orbit, so then we will call that as total extended maxilla. So surgery can be done via endoscopic route, lateral rhinotomy route, transoral, transpalatal approach, but most common approach, it remains the Weber-Ferguson. We'll see the types of incision and modifications of the incisions. Endoscopically, we can manage, but very, very early tumors which are confined to the maxilla and most commonly the medial maxillary. Then extent of resection, medial maxillectomy, inferior or total maxillectomy. So these are the most commonly used incisions as per the preference of the surgeon and type of the disease and involvement. So lateral rhinotomy incisions for medial maxillectomy, small tumors we can do, but the most common incisions which are used in practice are modified Weber-Ferguson, either with subciliary extension or natural lateral skin extension. So the D and E, these both are most commonly performed incisions as they give you wider exposure, proper flap elevation, and you can remove total maxilla through these incisions. So this is again from the Weber-Ferguson approach, tumor involving the maxilla, it has been removed, and you can see there is involvement of the orbit in this case. Then comes mid-facial degloving for the central lesions of the nasal cavity tumors. This can be practiced, but not routinely practiced. Then lateral rhinotomy incision, cosmetically it is very acceptable, but limited exposure. So you are not able to do complete surgery or even the infrastructure maxillectomy through these routes. Minimum incision that is required is the Weber-Ferguson incision with lateral skin extension. However, these incisions can cause eyelid edema, but these are temporary and they subside with the anti-inflammatories over a course of time. Subciliary extension, usually we don't prefer subciliary extension due to risk of ectropion. So we try to use lateral skin crease extension as it is quite away from the lower lid and there are less chances of ectropion. So as I show you the mid-facial degloving, it also has limited exposure. So medial maxillectomy. What is medial maxillectomy? En bloc section of the lateral wall of the nasal cavity, including inferior, mid-terminate, lamina papracia. So indications for medial maxillectomy, inverted papilloma. So this kind of patients, inverted papilloma patients, they can be dealt with endoscopic approach. Then low-grade, well-differentiated tumors to the lateral wall of nasal cavity, and for these approaches lateral rhinotomy, mid-facial degloving or modified Weber-Ferguson. So with modified Weber-Ferguson incision you can do all types of maxillectomies. So for medial maxillectomy, bone cuts we have to take from anterior wall enterotomy, then superior to alveolus, lateral to pyramid process, palatine, and vertically medial to the inferior orbital nerve, frontal ethmoidal suture, and posteriorly posterior wall of antrum. So it is also regarded as the conservative or type 1 medial maxillectomy, tumor limited to the medial wall. So just the medial wall is in these cases. Type 2 is extensive medial maxillectomy, in which medial and anterior wall of nasolacrimal duct is also removed. So this is the particular sequence of osteotomies in maxillectomy. So we'll discuss this in detail. Then comes the infrastructure maxillectomy. So widely practiced is infrastructure maxillectomies. All the lesions of hard palate, not involving the maxillary sinus extensively, not involving the middle wall of the maxilla extensively or posterior wall. In these patients, you can easily go for infrastructure maxillectomy. You will remove all the four surfaces of the maxilla from the lower half, including the palatine process, and very easily reconstructed. And there is less morbidity with these kinds of maxillectomies. So approach remains for this also remains the same. You can go for lateral rhinotomy or mid facial degloving and modified Weber percussion. So for infrastructure maxillectomy, bony cuts are taken first midway between the alveolus and then palate in the midline, medially, lateral nasal wall below the middle meatus, and posteriorly inferior portion of pterygoid plate. So you have to remember this, that the posterior extension should not go beyond the pterygoid maxillary plates, because then the bigger vessels, they come into the picture. So for taking all the interior cuts first, and lastly we go for the posterior cut of the pterygoid plates. So this is the palatal osteotomy, and then we have the osteotomy between the maxillary tuberosity and pterygoid plates of the palate. So here you can see that pterygoid plate is left behind, and just before the pterygoid plate, we are doing the last posterior osteotomy. Then comes the total maxillectomy. So as we all know, total maxillectomy is removal of entire maxilla along with the orbital floor. So indication for this is tumors from the mucosa which are filling the entire antrum, soft tissue, or the bone sarcomas. So for total maxillectomy, the preferred incision is only and only Weber percussion with lateral knees extension, lateral crease extension. Mid facial degloving, you are not able to do it. Then we'll see the steps of total maxillectomy. So incision we have discussed, modified percussion, incision with lateral extension, and then flap elevation. So skin flap elevation, you have to take care that skin incision followed by incision into the mucosa of the upper GPS. So from upper GPS mucosa, when you incise that, you start elevating the flap, and full thickness flap has to be elevated. It should not be in subcutaneous plane unless the muscles are involved. Only in those cases you can go into subcutaneous plane. Otherwise, preferred is you should stay close to bones, take some amount of muscle along with your flap. It should be a thick, good vascular flap, so that in post-operative period there are less chances of skin necrosis. Then so when there is no involvement of the bone is not breached, interresolved, you should try to stay over the periosteum of the maxilla. And take your flap as far as possible to the posterior lateral surface of the maxilla, exposing the undersurface of zygoma to gain access into the pterygomaxillary fissure. You have to take the part of pterygomaxillary fissure, the fat containing into the pterygomaxillary fissure, for achieving the complete negative margins. So soft tissue dissection, there are angular vessels which are the branches of facial nerve, facial artery. So these are encountered. These are easily cauterized, or you can place clips on these vessels. Then soft tissue of the face are elevated off the face of maxilla using the cautery or an elevator. So usually what we practice is plain monopolar cautery is sufficient to raise your flaps. Keep the monopolar settings on low current settings, and try to do very slowly so that you achieve proper coagulation without compromising the blood supply or vascularity of the flap which we are elevating. So strip away all the tissues around the maxilla up to the pterygomaxillary fissure and zygoma. So your landmark should be zygoma. You have to at least elevate your flap laterally to the zygoma, the posterior end of the zygoma, for proper exposure. So sequentially, medial palpable ligament is identified, lacrimal crest, lacrimal sac, and lacrimal fossa, and posteriorly up to the lacrimal crest. Divide the medial palpable ligament, elevate the lacrimal sac from the fossa, transect the sac as distally as possible. Then next, medial and inferior orbit is now exposed. So strip the orbital contents into the subperiosteal plane of the lamina papricia, and frontal lobe taking care not to fracture or penetrate the paper thin bone of lamina papricia. So in this total maxillectomy, you have to take care that you will take out the orbital floor without compromising the orbital contents. So this has to be taken care of. You have to protect the orbital contents first. Take your spacer, just put it over the eye, lift the bone in the right plane, and then you have to transect. Now do the osteotomies. So gently retract the orbital contents laterally. Anterior ethmoidal artery will come. You can ligate all the branches of the ethmoidal artery, posterior ethmoidal artery. Nothing will happen. Then strip along the floor of orbital in the subperiosteal. So this is the most important step while performing the total maxillectomy, to protect the contents of orbit and simultaneously take negative margins. You have to go into the right plane in the subperiosteal plane of the floor of orbit. So incise the mucosa of the hard palate along the planned medial resection margin, extend of, usually it is the midline in cases of total maxillectomies, extend the sublabial CN laterally around the maxillary tuberosity into the groove between tuberosity and the pterygoid plates. Just like the infrastructure maxillectomy, the lower end, the posterior end, the plane of dissection will remain the same between the maxillary tuberosity and the pterygoid plate. So after the flap is raised, all the soft tissue dissection has been done. You have delineated your soft tissue cut margins. You are ready for the bony resection, and particular sequence has to be followed while doing the bony resection. So sequence of osteotomies. This slide is the most important slide. This is the crux of the total maxillectomy. Flap elevation, anyone can do, you all can do flap elevation. Soft tissue margins, you can dissect very easily. You can make your future in CN, you can delineate the future in CNs after soft tissue dissection. But then comes the bony section. So always remember, first osteotomy which you have to done is through the inferior orbital vein along the orbital floor. Then through the frontal process of maxilla and lacrimal bone, then lamina papricia and anterior ethmoids, then palatal osteotomy, then osteotomy of nasal septum, and finally now the last, which is osteotomy, is the posterior osteotomy. Okay, so these osteotomies, particularly the last osteotomy, there is very much bleeding while performing the osteotomies. You have to take care. You have to do this process in the sequence and with time. You should have ample blood available. You should reserve at least 1 unit or 2 units of the blood. You can start transfusing right before the osteotomy if you are expecting high bleeding, or if you have high bleeding during the flap elevation or soft tissue dissection. So, so inferior orbital arrangement along the floor, osteotomy is placed lateral to the antrum, so that we are not entering the antrum. And so tumor, all the tumors, they have to be removed and blocked. If you have by chance breached the tumor cavity, then the recurrence rates are very high. So try not to enter into the antrum where the tumor is present. Otherwise, it will lead to the contamination of the surgical field, and the chances of recurrence, they increase. Then through the frontal process of the maxilla and lacrimal bone, it has to be the osteotomy you are doing, it has to be directed towards and below the level of frontoethmoidal suture line. Then through the frontal process of maxilla and lacrimal bone. So this is the osteotomy view for the first osteotomy, second, third osteotomy. Then comes the palatal osteotomy, which is the simplest, the most simple osteotomy to do in all of these osteotomy, is the palatal osteotomy and nasoseptum osteotomy. And the most difficult part in this osteotomy is the posterior osteotomy, whether it is infrastructure, whether it is total maxillectomy. The posterior osteotomy part is most difficult. You are going almost blindly. You are not aware of the vascular structures behind. The pterygoid plates are very hard to break, and sometimes you may have to use heavy Mayo scissors to just cut the pterygoid plates and achieve the you can then take out the specimen. So this is the palatal anatomy, and then osteotomy, and then finally the posterior osteotomy. So these are the osteotomy cuts for your reference. And then the bleeding, which we have discussed, it's mainly due to internal maxillary artery. This artery is, if seen, try to identify the artery and divide it wherever you see. So the main landmark to identify this vessel is the when it enters the pterygomaxillary fissure. So in all sense, pterygomaxillary fissure is of utmost importance. First, to decide about the resectability and the prognosis of the disease, then for the vascular control. Try to see this artery. This is huge artery, easily identifiable. Just clip artery at the root and take two ligatures of this artery, and then you can do your osteotomies very easily with minimal bleeding. Even after osteotomy, you have to look for this artery and clip this artery. Just take your mosquito or your artery, hold catch of this artery and clip it. So then comes the management of orbita. So now orbital cavity is involved. So what all we can do for the orbit involvement? So when the orbit contents are involved, we are left with no option other than orbital exentration. So involvement of any intracoronal fat, extraocular muscles, orbital apex, or involvement of globe, you have to go for orbital exentration. Particularly, we have to take care of the orbital apex. Sometimes orbital apex is also unresectable. Very meticulously, you have to see the imaging and discuss with the radiologist whether you are able to achieve negative margins. So orbital invasion usually present in 60 to 80% of the cases. Orbital exentration is the complete removal of the contents of orbit, including the eyelids. Though it is rarely required, but in some cases we may have to go for eyelid removal as well, and then we give the flap coverage of the orbital cavity. Then orbital clearance, as we all know, globe, all the muscles, extraocular muscles, fat, periorbita, these all are removed in orbital exentration. So there is also a classification for the orbital involvement, so to decide about the resectability of the tumor. Then orbital exentration. So usually the periosteum and fat and muscles, these are involved only, then we go for orbital exentration complete. And we always try to preserve eyelids, because for the cosmesis purpose. So once you have the eyelids, you can always go for orbital implants for the future rehabilitation and cosmesis of the patient. So same with the just like we did total maxillectomy, for orbital exentration, the periosteum has to be incised circumferentially, just medial to the orbital rim, exposing the underlying bone. Then medial and inferior orbital dissections are to be done, and orbital contents are mobilized, and relatively the planes are avascular, subperiosteal planes in which we do dissection. They are relatively avascular. There is hardly any bleeding, and this is achieved by simple stripping of the periosteum of the bone, and you have all the content in your head. And then the main important part which we take care is this transecting the ocular muscles and optic nerve at the apex. So orbital apex dissection is the most crucial part in orbital exentration, because all the other part you just go into subperiosteal plane and you can take out all of the content. Just you have to take care that all these muscles, optic nerve, the margins has to be negative, so they should be dissected much away, as much as away as possible. So similarly, there is posterior exentration also. So what what are the options do we have after doing the exentration? So basically, just we can leave the orbital cavity as such. It can granulate and heal on their own. Then after that, once the granulation tissue has covered up, there is healing as complete. Then we can go for implants. Otherwise, we can just take a small SSD, split skin graft, and we can place it in orbital cavity, which may improve the duration of the healing. And then we can just close the eyelids and suture the eyelids, and this is also a good option in some cases which in which we expect that patient is not going to afford the orbital implants. Then in some cases when they you have plastic surgery team with you, you have a complex setup with you, patient is billing, finances are in check, then you can go for free flaps, which can be a radial free flap from the arm, forearm of the patient, then ELT from the thigh, and then you can also do a regional flap, which is temporalis muscle. Temporalis muscles, the muscle is in close contact. You can just take off all the temporalis muscle from the origin and just place and cover the orbital cavity and even the maxillary cavity with the temporalis muscle. It is a very good option in which you don't have a plastic team or the finances are not available. The last option with ocular prostheses or implants. So these are also very, very good and very effective and very cost-effective method of rehabilitation. And then, so what are the supports of the orbit? What are the options for the orbital support? So skin graft to the periorbital region we can do, temporalis flap. So these are basically when you have done a total maxillectomy, you have removed the floor of orbit. You need to support the orbital contents. So somehow you need to reinforce the floor of the orbit through various methods. So simplest way of doing that is darning. So just take a Prolene suture, you can just form the artificial floor of the orbit. And the other thing is you can take a fascia lata sling. It is a very, very dense and very, very durable tendon, and it gives very good results. And then we can have a calvarial graft. You can just take the outer table of your of the patient's skull, just a rounded outer table of the skull, and just place in the floor of the orbit, and you can form very, very nice bony floor of the orbit. And it is also very easily done. Just place that below the floor of orbit. You can use bone wax for that along with the outer table. And the last one is the kind of costly method, titanium mesh. Titanium mesh can also be placed, but it has also wonderful results. So these are some reconstruction pictures. So you can see the temporalis muscle. So from the origin, fan-shaped muscle, huge bulk, very, very good muscle to cover the orbital content. Most cost-effective method of to cover the orbital content is temporalis muscle. Just adjacent to the orbit, you can harvest this muscle, keep the lower attachment attached, and just place and rotate the muscle onto the orbit. So as we discussed the unresectability, so unresectable tumors are those which are superior extending into frontal lobes, cavernous sinus, prevertebral fascia, bilateral optic nerve involvement, and distendments. Apart from this, borderline resectable tumors in which you have internal carotid artery involvement, the patient is not fit to undergo major procedure, you don't have a reconstructive team with you, those are also potentially unresectable tumor depending on the situation.
So with complex surgeries, there are always associated risk of complication. So particularly some complication related to the incisions, subciliary incisions, as we discussed, there is chances of eyelid complications, there ectropion, prolonged eyelid edema, and even some middle lamellar contracture syndrome. And then hemorrhage. So as we discussed, the hemorrhage while performing the posterior osteotomy, hemorrhages, the risk of hemorrhage is very, very high. If you are performing this surgery not routinely and you are trying to do in your early course of career, make ample arrangement of blood, start the transfusion just before doing the osteotomies, so that you have your patient hemodynamically stable all throughout your operative procedure. Then CSF leak, it may also occur, and sometimes CSF leak, usually it resolves conservatively, but sometimes it doesn't resolve, then we have to intervene surgically to repair this. Then other post-op complications, facial edema, then if you have done a flap coverage, then flap necrosis, infection. Usually infection rates are very high due to presence of oral cavity, and there are dehiscence of the sutures. Then oral nasal fistula, speech and swallowing problems. So rehabilitation, we have to take care about the speech and swallowing problems, particularly in maxillary tumor swallowing problems. So you have to cover the defect and give adequate swallowing to the patient so that he can or she can stay on oral feed throughout his life. So now the reconstruction of maxillectomy defects, it basically depends on the classifications given for the defects of maxillectomies, and the most common or most widely used classification is Brown et al. Classification. So according to the defect, we choose for the reconstructive procedure for these maxillectomy patients. So what are the various reconstructive options for maxillectomy patients? So if there is minimal defect and you then you can just go for free radial flap or ELT flap. Then low maxillectomy not involving the orbit, you may go for fibula flap or iliac crest flap, or you may avoid the any bony reconstruction, just give a flap coverage with the radial or ELT. Rather, ELT is more preferred because ALT has much fat content, and it gives a huge bulk to the maxillary cavity, and cosmesis wise and rehabilitation wise, ALT is the best method to reconstruct any maxillectomy defect. Apart from the infrastructure maxillectomies in which you can go for radial free flap, it has very less bulk, it has skin, subcutaneous tissue, no muscle at all, but it gives very cosmetically appealing coverage, and it is good for infrastructure maxillectomies. But total maxillectomy, ALT is the choice of free flap. Then other classifications like Cordorio and Santa Maria. So all these classifications basically they help you decide whether you are going for which kind of reconstruction, how much is the tissue loss, how much is the bony loss. So the advantage of maxilla is that it has no articulation while swallowing. So we don't routinely require any bony reconstruction for the maxilla, only in cases where there is huge defect, and to improve the cosmesis we go for bony reconstruction so that we can give a better cheek shape to the patient. But for swallowing, bone has more role in maxillary tumors as compared to the oral cavity and mandible tumors, in which we require a bony reconstruction for the swallowing purpose. So again, the another classification can be OK and Urquis classification. And then comes the role of obturator. So this obturator you all might be knowing and all might be using and preparing obturators for your patients or maxillofacial surgeon patient or surgical oncologists patient. So obturators can be of three types. It can be interim obturator, temporary obturator, permanent obturator. So the best way to give coverage in a low financial settings, I would say rather, is the obturator. So just get a pre-assessment done and make an interim obturator for better healing, early start of oral feeds of the patient. Interim obturator is the best modality, and after that you can always go for permanent obturator, which gives aesthetically it is very better, functionally it is very better. Who are not able to afford the free flaps surgery. So obturator, basically what is the function of obturator? It serves as a levine tube for feeding purpose. So it gives the coverage to the maxillary defect and keeps the defect clean, and also helps in healing of the wound. It enhances the healing of traumatic and post-surgical defects as well. It establishes the palatal contour of the soft palate. So this will help in one, speech,
Second, swallowing. Third, aesthetically, it is very better. And then it improves the mastication, deglutition, and prevents the flow of exudates into the mouth. And it can use as stand to dressing or pack. So you can just apply the split skin graft in the maxillectomy cavity. You can do a packing of the maxillectomy cavity and then put an obturator uh, onto the palate. So your maxillary cavity is protected and it helps in healing. It helps in controlling if there is any superficial bleeding over there, or there are any secretions which are collecting in the cavity. So just remove the obturator, clean this area, and just apply the obturator again. So types of obturator: metal obturator can be used as static obturator, and it is obliquely upwards up to the hard soft palate junction to close against the terminates and superior aspect of nasal cavity. It is usually preferred when the cleft is wide and patient has an active gag reflex. Then, so this is the metal obturator. Then comes the surgical obturator, which we use in maxillectomy patients. So as we discussed, it improves the oral function, speech, swallowing. Both functions are regained very easily, and the recovery of the patient enhances on a rapid scale. So these are the types of surgical obturators. Then temporary obturators or interim obturators. These can also hasten up the recovery process by facilitating the patient to take the oral feeds. And once the healing is complete, now we are ready for the definitive obturator. All the contraction that has happened is now settled. The surgical cavity is now static. There is not going to be any change. So now we can go for the definitive obturator. In patients who are not affording for the free flaps, this is the best modality which can be used and cost-effective modality. So these are kind of some definitive obturators. With this, I end my slideshow webinar for the today, and I thank you all for your patient listening, and also I thank Denti team and AB Dental Talks for organizing this webinar for the benefit of all. Thank you so much.
Thank you so much, Dr. Sethi. I'm Ragni from Denti Software. Thank you again for enlightening us with your insights and wisdom. Your words have left a lasting impact and inspiring us to think, learn, and grow more. So, thank you for attending, everyone. If you have any questions, you are please welcome to ask questions or drop. You can unmute yourself, or you can drop your questions in chat box. That is also possible. We can start our question and answer sessions. Anmol.
Hello.
Dr. Sandeep, Dr. Shukla.
So, and any queries, anything you would like to ask apart from maxillary tumors also, you can just ask.
Yeah, you can raise your hand. We will unmute you so that you can literally ask directly, or else you can drop questions and question and answer session. Okay.
Ragini, I guess there is one question by Pratyush.
In the column.
He's asking like any courses for maxillofacial rehabilitation. Why?
Yes. There are many courses which are going at the oncology centers. large dedicated onco centers. They are providing courses and even training to the MDS students for the maxillary tumors and rehabilitation. One of our student from my last center has already joined. So HCG Nashik, I think that institute is giving a formal fellowship in oromaxillofacial surgeries, maxillofacial oncology as well.
There is a token of thanks from Dr. Naveen. Very lovely session. Thank you, sir.
Welcome.
So I think people will drop a message in our chat box. We will wait for that. Till now, we'll try to introduce you about, like, I'll give you a brief introduction about Identi. First of all, thank you so much, Doctor, for illuminating. Your presentation has been not only enrich our understanding, but also inspire us to elevate our practices. We appreciate your valuable contribution and look forward to future enlightening sessions like this again.
Sure.
Okay. So as we embrace the advancement in technology, let's now dive into the innovative realm of software products that play a vital role in shaping our digital landscape and daily practices. Now I will try to share my screen with you.
Sure.
Yeah. Ketna, can you please help me? I think, Doctor, you will have to stop
sure.
sharing your screen.
You can
Just a minute. I'll
share your screen. Again, you can share your screen.
Yes, I am. Thank you so much. Is it visible?
Yes, it's visible.
Yeah, thank you. So in Denti, we are providing 4 business vertical, like manage, educate, buy, and discover. From manage, mostly we are gonna conduct, like, providing you the management for your doctors, staff members, and clients, patients, their appointments and their treatment, billing, everything. There are going to be reports according to the feature we have provided. Second is educate, where you can publish, like we publish information about the courses or the conferences happening in India, so that as a doctor or a student in this industry, you can go visit over there and look forward all the information you can gather from there. Third is Denti Buy. Basically, it's an online a platform where you can offer any supplies related to dentistry, like starting from syringe, suction tapes, intraoral camera, X-ray machine, any agent, everything is available over there. You can opt for home delivery as well if you like the product. Last but not the least is Discover, from where you can publish your profile. You can create your digital visiting card. You can create your website from Denti domain. We have that provision. I'll show you the sample of that later in the software presentation. Now come to the Denti Manage. Here in the right hand corner, you can see that these are the modules we are going to provide, like patient, appointment, message, account, lab work, report, document, administrator, inventory. On this appointment page, with the use of this group view button, you can see that we have multiple doctor for which every appointment has been separated on their separate column, so that you can see that for Dr. Agni, there is an appointment for 3:30, there is an appointment for 11 o'clock. For understanding, better understanding for your staff member as well as for your doctors, you can separate their appointment, you can book their appointment. Patient as well as doctor will receive a confirmation message, taking feedback, that is also an option over there. Then after booking an appointment, this is a day view. We have given the privilege of week view, month view, agenda view. Whatever you feel comfortable for your clinic, you can opt for that. Suppose your doctor is not there, you want to block and timing for that particular person, is that is also possible. This doctor is not available, so this time slot has been blocked by the staff member, so that there should not be any mistake to book an appointment for a particular doctor. Afterward, this is the schedule listing. You can see that there are the 7 people we have scheduled for today, on which whenever that patient will come, we will move to the checking part. There is a waiting list, there is an engaged list, there is a completed list. So at the end of the day, if you want to see that how many patient has completed the appointment, how many missed the appointment, so that you can connect with them, reschedule their appointment, all those options are also available. This is an action button where you can mark your patient as missed. You can send feedback message, you can send WhatsApp SMS, which is WhatsApp integration is also available. So yes, this is the appointment view. Moving to the patient's case file. Suppose this is a sample patient for your patient Rima, in which we have given these sub modules, which is profile, examination, treatment, prescription, file, and billing. On the profile page, these are the sub options, features we have given. You can add your personal information, you can add emergencies. It will, like, as soon as you will add it, you have added these emergencies, it will reflect in right hand corner permanently. So first, your Dr. A is not there and Dr. B is taking in charge of that patient, so he has a habit to see in right hand corner what are the emergencies he can take account of. Then you can add account details, you can add medical history, you can add investigation, allergies also there, dental history, insurance history. Though we have given so many options, we have also given the option for adding personalized attributes. Suppose you wanted to add blood group, but it was not there, so you have a you have a ability to add your own columns. That is also possible. That much flexibility we have given in dentist software. Moving to the examination part. So now, till now, your staff member has done the all of the work. From your examination, treatment, and the prescription, this job will be done by the doctors, like adding first examination, which is first conversation with your patient. What are the chief complaints are? What are the diagnoses are? So since anything, it's already there. You can just search for the words, you can find those words in the listing. But in case you find it something are missing, or you want to add new entities, that is also possible. So every other listing you can edit from your side at your end itself. So that is your examination. Even dental chart is also there. It's a great representation. Color coding is there. So when it comes to have the conversation with your patient, when you need to explain what is the procedure, what will gonna happen, it will be very much easier if you take the help of this dental chart. Periodontal chart is also there. Many doctors from India are using the dental chart nowadays. Moving to the treatment, again, in treatment we have given two options. One is normal adding treatment. You can just add treatment, move to the billing part, or else if you feel like you need to give few options to your patient, like for example, option A, you can do the 10-year crown. Option number B, you can do the crown for 20-year warranty. Option number C, maybe you can go for lifetime year warranty wala crown. So in that case, patient will decide according to the price perspective what options they want to go for, and in that case you will confirm that order, rest you will cancel. So yes, for giving the quotation or for giving the multiple option, you can use this treatment plan option. Here also we have given one more option to share through the SMS this plan for approval. Means maybe in future, if they have any kind of a misunderstanding or a confusion regarding to the pricing or the quotation, you can have the digital signature from your patient itself for the approval. So that provision also we have given. Moving to the prescription part, now it's very easy. You can just click on add prescription. You can add multiple names of medicines, dosages, frequency, add notifications like notes like before after meal. But we have also given the shortcuts to create your template priorly itself. Suppose I'm a patient for root canal, you can just select the template for root canal. Within a second you can give a printout to your patients. Again, for sharing this all information, like it can be a treatment or a prescription or a bill, you can share the payment through these many options. For sharing, we have given the option for WhatsApp. You can share through the email, you can take a printout. So yes, connectivity with your patient is also very easy through the dentist software. Moving to the files, we have two options, like you can upload your files like x-ray, blood work. You will just have to upload a upload those files over here. Moving to the consent form, again this is very important in dentistry. Prior doing any procedure, you need to take consents from your patients. So again, you can share these digital consent forms with them. They will do the digital signature on their screen touch mobile and immediately will share with you. Now they are saved in your software permanently. This is a sample for your consent forms. This is a digital signature in left hand corner. As I'm showing you, this is how you can take a printout and share with them. Okay, you can do all the signature via digital format. Moving to the billing section, very easy. After creating treatment, you will create an invoice, and then the patient will do the payments. It can be one-time payment, it can be a multiple installments. Accordingly, you will add the receipts. Again, this is the action button through which you can share your print with your patient, like print or email, or you can share through the WhatsApp. All options are given over there. Moving to the last, like appointment part. After billing, we usually tend to book an appointment for next time. Here it is a shortcut for that. In upper corner, there are few shortcuts like patient summary. Like you can take a print out for your digital information. Like this is a digital report. Their profile information, examination information, treatment information, everything will be available. Or else you can choose in between what information you want to share with them, so that you can take a printout or you can share with them through the email. So that was your patient summary. There is a shortcuts for adding investigation. This is a shortcut for adding consent forms. There is one more important feature, which is patient portal access, through which you can share your information with your patient digitally. You can switch on this button. They will receive a link through the message, and by creating their password, they will be able to offer what treatment you have added for them, what prescription you have added for them, all the information about their billing, current paid amount, or the balance amount. Obviously, they won't be able to edit anything, but yes, they will be able to access all the information you have added for them. So usually in foreign, this option has been used by every other clinic. So yes, there is a very advanced feature, which is patient portal access. Now moving to the other features like accounting. So here, in many cases, many clinic, they need to export their data related to payments or the billing at the end of the month or at the end of the year to share with their CAs or accountants. So from accounts, you can do that. There is one more option, which is petty cash. So as a clinic owner, you will have to add your expenses somewhere. So it can be a rate, it can be a water supply, it can be electricity bill, all those information, your staff member ka salary, all those information you can add in petty cash. Moving to the lab work. So for crowning, this is very important tool. You will manage your labs. Like suppose I'm creating my crowns from few labs, so I will add those labs number and everything details over here. Now for adding my crown ka lab work, I will put forward my patient's name, doctor's name, dates, from which lab I'm ordering, it is a new case or an old case, what is the shades, what are the scent, I can select my stage, tooth number, then later what is the component, what is the price I need to pay to my lab people, Pontic design, color design, every other details I'm gonna feed it over here. Now on the basis of these three things, like I have placed the order, I have received the order, and I have the completed order, I can segregate my all data. So now after submitting this, I will get options to see that how many appointment has been completed in particular time of period, or how many appointment has been placed or received. So accordingly, I can manage my all data. Moving to the report, again, we have given so many features in NT software. In accounts of that feature, we have created these reports. Like when I'm booking an appointment or when I'm creating a new patient case files, in that case, now I want to analyze that how many patients I have collected from this particular month, who was the doctor in charge, from which communication group, all those filters I can provide. So I will get an exact number. Revenue analysis, how many collection report, outstanding report, doctor wise record, work report, which is how many root canals I have done in particular time of period, work-wise report. That means from Dr. A, how much collection has been done, clinic dashboard, clinic insight. These are the graphical reports through which you can analyze the downfall or the growth of your clinic, patient-wise, appointment-wise. So obviously, if you analyze your data, it will definitely help you to grow your all clinics growth. Moving to the administrator, basically this is the brain of the software. You will add your managed staffs in managed users, you will add your doctor from managed doctor. Now from user role access, you will decide how much data you want to share with your particular person as per your convenience. This is a managed master. These are the 9 columns where all the listing we have created in dentist software you can edit. It can be a treatment type, it can be examination, it can be a medicine. You can add your template from here, you can edit dental chart. All those options you can edit from here. Additional to this, we have printing settings, we have personalized settings, there is a recycle bin, there is a walk log activity. So obviously as a owner, you can see every activity has been done in your dentist software from there. Moving to the inventory, also this is very important for your stock entry. You will add stock supplier's name, you will manage those things from here. Then you will create a group. Accordingly, you will add your entity's name with the minimum order quantity. So that database has been created. Now when you purchase the order, like suppose I have ordered 10 air rotor today, so I will put a purchase order from here. When that will come in our clinic, I will add the stock entry as plus 10 that product in my stock entry. Now whenever I want to create a sales order with my customer, I will create it from here. If I want to maintain my customers database separately, that is also possible. And now in a stock, we can see that currently how much stock is there. You can select your date time from here exactly, and you can see the view. There are few entities which are in red in color, it can be green in color. So significance is those who are in red in color, that means this is a lesser than minimum order quantity and you want to reorder. So that is very important for the inventory. Moving to the CRM, so basically in many clinics we put forward an advertisement on particular platforms. So now we are getting a leads from there, but how we are going to manage those things? So we can create a lead group, like for example Facebook, Instagram, and on that platform I'm getting my leads, suppose. So I'm creating my leads over here. So as a caller, we can call them. Till now it's just a mobile number and a name, so they will give us a reminder, like for example, we are busy today, call me tomorrow, day after tomorrow, maybe after 6 months, so that you can create a reminder for yourself. And you can see all those calendar view over here, like what is your today's to-do list, you can see over there. So you can manage all those leads you are gathering from there, so that whenever that patient comes in our clinic, we can directly add them in our patient list. Okay, so that is all whatever we have provided in Denti software. Additional to this, there are 2 features, that is website from Denti domain. Here this is a sample website, wellcare.denti.in. There you can add your banners, you can add information overview about your clinic, services, timings, what you are providing. You can put forward your doctor's profile. Suppose you want to add their achievement, their experience, consultation fee, awards, registration details, you can add that. You can add all the services you are providing. In fact, you can add the information about your specific treatment you are providing in that column itself. You can take a feedback, you can gather feedback. It's a great tool over here. In the gallery, you can put forward images of your clinic, or the campaign you have done, or the achievements, or your special outcomes, before after photographs, celebration you are doing in your clinic, your equipments you are having. You can put forward those information in your gallery. Contacts us, everything, like your social media account handlers, your map, phone number, WhatsApp number, address, everything is going to be there. So this is your website from Denti domain. Second option we are going to provide you, which is digital visiting card. Again, this is a great tool when you need to share your information with anyone. You can share this link with them and it will be saved in their WhatsApp permanently. And whenever they want to forward to give anyone to for their references, again that particular person will be it will be very easy for that particular person to connect with you, because address is there. To book an appointment, it is directly connected with your dentist software, email ID, mobile number, or your social media handles. Everything is there. Okay, so that is all. As we conduct this insightful webinar, I want to express my sincere gratitude to each and everyone who has attended this seminar today. Your engagement have made this session truly enriching. A special thanks goes to Dr. Sethi for sharing their expertise and insights. Your valuable contribution has left a lasting impact on our understanding of dental health. We appreciate the time and efforts you dedicated to making this webinar a success. Thank you once again, everyone, for being a part of this meaningful session. We will look forward to future opportunities to connect and learn together. Thank you so much. Have a great day ahead, everyone.